So nailing in extreme tibial fracture, unstable construct, technically demanding on historically high malignant rate, proximal as well as distal tibial fracture by infrapatellar approach. So issues in nailing in metaphyseal fracture, deforming forces, entry point and placement of the nail. So these are the three issues we have to solve while doing nailing. Apex angulation is the most important thing in a proximal tibial fractures, and quadriceps is the deforming force in proximal tibia which displaces the fracture anteriorly, and more so it is very difficult in an infrapatellar approach. And in fibula is the deforming force in distal tibia up to 7 to 8 centimeter in the distal tibial fractures. But what is the most crucial in the tibial nailing success is the entry point is crucial in the proximal tibia, and the center position of nail in a distal tibia to maintain the tibial plafond both proximally and distally horizontal. So to overcome deforming forces and fixation of complex tibial fractures by nail, what is the solution? And solution is a suprapatellar nailing in a semi-extended position with adjoint clamps, polar screws to reduce and stabilize the fracture. So the current indications of nailing certain intra-articular fractures and extra-articular tibial fractures within 50 mm in proximal and 30 mm of distal plafond. Dr. Vivek Trika is here. He is very much fond of doing a suprapatellar nailing in intra-articular fractures of proximal and distal tibia. His lecture is available in YouTube. You can go through it. So semi-extended position, and use a multi-lock nail to be used in a suprapatellar nailing. Bolstered under a knee to maintain 15 to 20 degree of flexion. And one precaution we must take, we must have a lateral support, because the thigh tend to go in a 20 degree of a flexion into a lateral position. It is externally rotated, so you will find a difficulty in finding a entry point. Therefore, you must have a lateral support to the thigh. So this is an example, a compound extreme proximal tibial fracture, and you can see that the fracture has extended up to the inferior pole of the tibia, and you can see how it's a compound fracture with a soft tissue injury. We should wait for a number of days to do a nailing or a plating, and probably plating is the gold standard will be in this case. Infrapatellar nailing will be difficult. So what I did, a clamp assisted reduction, and you can see where the fracture is stabilized, and then stages of surgery, a polar screw and a suprapatellar nail, and apex anterior fixation, reaming and nailing, and one additional polar screw to stabilize the proximal fragment, and 1 year follow-up radiological and functional outcome. You can see that there is some issues with the slope of the tibia, but that did not matter very much. Full patient is able to sit and squat. Another example, a 45-year male polytrauma patient, compound fracture femur, segmental fracture tibia, clavicle and lower end radius fracture, and such a hastine with multiple injuries. So what I did, after 7 days, a patient was taken for surgery. Second, a suprapatellar approach and close tibial fixation for the tibia. And then you can see by infrapatellar approach, a multi-lock supracondylar nailing for femur transtendinous approach. Both mini-invasive surgery. And you can see the placement of the nail, multi-lock distal femur and multi-lock proximal femur, proximal tibia. And so ultimately, post-operative fixation of segmental fracture of tibia, close, and a supracondylar fracture with a distal femoral nail. And you can see here how, and ultimately after 2 months, And for 4 months, the distal femoral fracture required additional augmentation plate with bone grafting for a union. So another example, a segmental fracture, you can see a very extreme, very difficult to stabilize, most unstable fracture, clamp assisted reduction, and then you can see a skeletal traction, calcaneal pin, insertion of a posterior polar pin, and then stages of surgery, entry point, guide wire, and reaming. What is the most important thing in a reaming in a segmental fracture? You must stabilize the middle segment. Otherwise, there is a spinning of this, the fracture will occur, that's the segment will occur, and you will damage more. You will damage more. Therefore, you must stabilize with the clamp or manually, and otherwise, you don't ream that particular area, just push the reamer distally and then you start reaming. So probably it is better to put a rigid reamer first through the segment and then you can judge the canal and then do a sequential reaming. Passage of the nail, locking, a mini invasive surgery at 3 months, 6 month follow up, a functional range and full movements. Another example, a 15 days presented from other hospitals, still there is a wound. It's because of the blister, they never healed, and probably patient was restless what to do. Plating would have been the better answer. My hand is such a comminuted segmental fracture. What I did is what to do, and then had a suprapatellar approach, clamp assisted reduction, bypassing your all blisters and everything, and then mini invasive surgery you can see here, and then ultimately the final placement of the male, minimal invasive surgery, and after healing of that particular wound on the medial side, augmentation plate, 3 months follow-up, and you can see a 1 year follow-up, everything healed around the nail with a span plate. Another example, the segmental fracture of the tibia, impending compartment syndrome, fasciotomy, skeletal traction was given for some time, and after 3 weeks of surgery, what it did, a suprapatellar nailing and simultaneously a skin grafting was done to that particular area. Bypass surgery, fixation was in distraction, dynamization was done, and this is a 3 years follow-up. You can see a perfect anatomical restoration. Another example, you can see such a segmental fracture with a lacerated wound and raw area, with a lacerated wound and ankle exposed. So what to do? A controlled hypertension, tobacco, extensive top shift to involvement, and in such a situation, clamp assisted reduction, posterior polar pin, placement of the guide wire in the center position, suprapatellar approach, reaming, and then ultimately this is how we have to stabilize by a clamp, a middle fragment, that is the most important other to avoid the spinning, and distal and proximal locking, minimal invasive surgery. You can see the wounds are there, debridement of the ankle wound, and ultimately you can see after 4 months, wound healed, union is progressing, good range of motion, patient is able to walk, and he has joined the duty as a labor. Another example, a very segmental fracture, multiple pieces with intra-articular extension, mini invasive surgery, span plate with the suprapatellar approach, bypassing everything, clamp assisted reduction, and you can see here 3 months follow-up, everything healed. And these are the restoration of the articular surface. I do agree that there is some depression, but 5 mm depression does not measure, and patient is able to sit and squat. Another example, a very interesting 44-year male compound comminuted fracture, extended to joint, was treated in other hospital with a debridement and wound and X-fix. And you can see here how this is the fracture, a complex tibial fracture with the involvement of the articular surface with the widening of condyle, and a very displaced fibular segmental fracture. This is the position, clepsula grown, removal of the X-space, window of 10 days and locking plate external fixator was in. The patient, everything healed. All wounds were healed, and you can see the patient was happy and I was also happy. But there was no consolidation even after a 4 months of follow-up. So patient was restless because there was nothing, and then I was also restless what to do. In a situation, there was no point in doing a bone grafting also. It's because the skin anteriorly, it was not very good. So ultimately, why did? Creating a part through the sleeve of a suprapatellar approach by 8 mm rigid pointed reamer, and then I used a past guide wire because it is very difficult to negotiate through that multiple pieces with a fibrous tissue. So I negotiated anyhow, you can see with stages, past a guide wire, then reaming by this, and ultimately subsequently bypassing everything from the tibia through a suprapatellar approach, putting the screws in the very good area distally and proximally, leaving behind all the tissues there, 6 month follow-up, 1 year follow-up. You can see what exactly you want more than this by suprapatellar approach. Another example, with a very displaced fracture, complex injury, segmental fracture, it's a direct injury, and you can see a fracture with a very bad soft tissue. I designed external fixator and subsequent nailing would have been possible, there is no issue. I did a bypass surgery, and you can see a 1 year follow-up, perfect anatomical restoration and healing of the tissues. Another example, after waiting for near about 15 days, the blisters and everything is still there. A complex tibial fracture and a spiral fracture of the fibula proximally. To maintain the plating would have been the best option. But you can see here multiple blisters are there after waiting 15 days also. So what to do? And ultimately, dilemma, nail or plate, a bypass surgery, a segmental fracture, you can see calcaneal peel traction because it should not come in the way. For infrapatellar, it is very difficult to maintain the position and to see the CR. It is one of the best method to treat the proximal and distal tibial fracture, clamp assisted reduction, and these are the stages of surgery. Centralization of the guide wire, then there is a polar pin, putting the guide wire, then reaming, and ultimately this is the post-op. Bypass everything, don't do anything. All fracture will go under the stable fixation, more than 3 screws in a distal tibial fracture, and stable fixation leads to healing. And in mechanically incompetent but biological while fragment in comminuted fracture, they heal if you fix proximal and distal fragment very perfectly and by stable fixation. We cannot say it's a rigid fixation, but the stable fixation will produce a very conducive atmosphere for healing, and heals by callus formation. Another example, a distal tibial fracture with stitch wound presented after 18 hours, calcaneal pain, debridement of the wound, and then ultimately you find this is the gap was available after debridement. So what I did, I passed a nail, a fibular nail, that is the screw intramedullary nail after reaming, closed method into the fibula and fibular nailing to restore the length. And ultimately you can find a suprapatellar articular screw, apex neutralization plate, augmentation plate, and then ultimately what I did, a plastic cover. And this is the post-op X-ray, 3 months follow-up and 6 month follow-up. The all comminuted pieces, what it said, in a comminuted fracture, nailing should not be done. I don't agree. because nailing takes burn of the lateral tissue incision and probably it prevents a soft tissue damage. So over the years of time, I have found that the fibular nail screw intramurally it restores the length and it can be used in a comminuted fracture and you can see a complete consolidation of the fracture. Another example is segmental fracture with a very soft tissue injury, bypass surgery, centralization of the nail, and you can see a perfect anatomical restoration. Number and position of a distal locking screw is determined by the fracture morphology. Insert the greatest number of screws distal the screw as possible. Proximally more than 4 and distally more than 3. In case if you require, you can use a polar screw because two poles must be in a stable construct. Another example, a segmental fracture, very proximal fracture you can see here. And how to do a clamp assisted reduction, suprapatellar nailing. These are all stages of surgery. And you can see here a stable fixation recently done. Patient is walking in 6 weeks follow-up only. And I telephoned yesterday, he said, मैं तो ट्रक चला रहा हूँ. So then you can see how it is. So another example, a very complex proximal tibial fracture with anterior extension. And you can see here, plating would have been the best option. And what I did, intramedullary nailing and a small augmentation plate just for apex neutralization to have a stability in oblique spiral fracture. Difficult nailing, 1 year follow-up, complete remodeling of the proximal tibia with the additional plate and suprapatellar approach. Another example, a very ghastly segmental fracture with a segment is coronally split. You can see here, segment is coronally split and even after 3 weeks, this is the situation. What to do? Did a suprapatellar approach. These are the stages of surgery. Bypass everything. Don't do anything to the soft tissues. Go from the very good area of a suprapatellar approach, and this is how a perfect anatomical restoration. Union of the segmental fracture in the literature it is said that more than 60% of the segmental fracture requires a secondary surgery. But in my observation after suprapatellar nailing, very few require a secondary surgery if you do it very gentle, a suprapatellar approach. Another example, a compound fracture, supracondylar femur and a complex tibial fracture after alcohol intoxication. And see this shattered tibia with all segment contaminated wound with a complex fracture. And see debridement of the wound and temporary K-wire fixation in the night with a calcaneal plaque and a immobilization in a thymosus splint. And after stabilization of the thing, secondary debridement after 36 weeks through wound suprapatellar nailing and infrapatellar approach supracondylar nail. Nobody will agree that in such a situation, nailing should be done. Yes, I did it with the press, and you can see antibiotic cement beads around the fracture and primary closure, and ultimately wound after 15 days of X-ray, the patient had a beautiful healing without skin grafting, and you can see here how this is the this is after 3 months follow-up. There is a good position of the supracondylar area, still antibiotic beads are there, and the complex tibial fracture is there, radiological and functional outcome. This is 3 days ago X-ray and the patient's follow-up. So you can see how everything heals around the nail, and after stabilization of the fracture, the soft tissue also heals. soft tissue analysis. So a suprapatellar intramedullary nailing advantages of fracture fixation. It is potential for minimally invasive exposure, biologically friendly implant insertion, longer implants to span more complex fracture, and load sharing fixation to allow early weight bearing. No need to change the position of the limb after reduction of the fracture while doing surgery. And I tell you, suprapatellar nailing is a friend in need, is a friend indeed in a complex tibial fractures, in the management of a tibial fracture. So this is already now, it is under publication, accepted for publication in Sikarche. It's in the forthcoming issue. Probably in the next month, it will come online, accepted on 13 August 2023. So thank you very much. And